Ileus and severe overdistension can occur postoperatively or spontaneously as the pseudo-obstruction of Ogilvie's syndrome. Colonoscopic deflation very quickly removes the gas. However, in many cases the problem recurs unless a deflation tube is introduced and left in position. One approach is to pass in a stiff gastroscopy guide wire using a flexible sigmoidoscope. The scope is removed, leaving the guide wire in. A short, stiff flatus tube, with a hole drilled in the end, is passed in over the wire and the wire withdrawn. The tube is joined to a drainage bag. If a long colonoscope has been used, either a purpose-designed colon drainage set may be used or a biliary stent set as for ERCP. The stent is discarded, but the introducer tube and guide wire are passed in together and the scope withdrawn. The stent pusher tube is then inserted over the first tube and guide wire and remains as the drainage tube after they're both withdrawn. Cutting some extra drainage holes in the pusher tube beforehand is easy enough, and it's stiff enough to stay in position, with syringing every few hours if necessary to keep it clear. An alternative approach is to carry up the deflating tube alongside the colonoscope in the first place. A silk suture is looped through the tip of the tube, and the knotted suture can be grasped by the colonoscope forceps. The forceps let the tube go when the scope is far enough in.